Our first speaker today, this afternoon, is Michael DeRosa. He's been a practicing OBGYN for more than 30 years and has been affiliated with Sherman Silber and the Infertility Center at St. Louis in the United States for more than 20 years. His research interests and clinical interests include laparoscopy, hysteroscopy, surgery, fertility preservation, and adenomyosis. And he'll be talking to us today about Mini-IVF and epigenetic perturbation.
Thank you. I'd like to first thank the Ovarian Club for inviting me here today. But really what I really like to thank is Dr. Silber, because 20 years ago, he gave an OBGYN like me the opportunity to do something I never dreamt that I would ever do, and that was to help people get pregnant. Over those years, I've seen a lot of changes. And this morning in his talk, I saw patients that we did ovarian transplantations on, and it reminded me what an awesome, awesome job we all have in helping patients get to one of the most important things in their life, having a baby and a family. And I'm looking at his slides this morning and helping him with ovarian transplantation. As an OBGYN, I not only have the ability to be on the upfront part of it, but I also have the awesome honor to be at the back end. Amy, the leukemic patient, I delivered her baby 4 years ago and just recently 3 months ago. And I can tell you that the work that you and all your predecessors have done is absolutely amazing. And as a clinician, from the bottom of my heart, I have to thank you all for doing that. Now, I was asked here to talk about mini-mild IVF, and Dr. Silber actually is going to be doing the epigenetic perturbations of the talk. I have no disclosures. You know, when I first started looking and researching for this talk, I knew what Dr. Silber and I did for years. And I knew that our stimulation protocols went from conventional to mild to mini. But in preparing for this talk, I realized that well, let's just get started with the talk. In 1978, Dr. Edwards, using natural cycle IVF, the first IVF baby was born. But as I was going to say, I wanted to make this talk entitled, "Is Less More?" Because in the United States, our patients seem to want more. They seem to want more embryos, more eggs. They want more clinical things like DHEAS, testosterone, growth hormone. They want acupuncture. They want you to test natural killer cells, intralipid injections. They think more is better, but really, with all those clinical changes, does it really make a difference? Or is it really hurting the patient? And so in 1978, the first baby was born by a natural IVF cycle. But gonadotropins were now widely used in controlled ovarian stimulation. And what did that do? That gave us more. It gave us more oocytes, it gave us more embryos, and in fact, gave us better success rates when compared to natural IVF. But it also was without cost. It was increased cost and the increased risk of ovarian hyperstimulation and multiple pregnancies. In 1996, Dr. Edwards and his colleagues called for a milder approach to IVF stimulation protocols because they were concerned about multiple pregnancies, hyperstimulation, etc. Fauser, in 1993, introduced the window concept. And that window concept is really what we utilize today for ovarian stimulation. It emphasizes the importance of a transient increase of FSH above the threshold. What we see in the spontaneous cycle, we see that FSH levels increase. And as they increase in the mid-follicular phase, the granulosal cells are creating more FSH receptors and becoming, have a higher sensitivity to FSH concentrations. That's important because as FSH decreases, that increased sensitivity enables the dominant follicle to grow, while the other follicles without that sensitivity become atretic. In conventional stimulation, excess exogenous FSH remains above this level, and therefore multiple dominant follicles are created. But in the mild stimulated cycle, these levels are decreased, decreasing the number of dominant follicles. So what would be the ideal stimulation protocol? One that would minimize cost, reduce the amount of medications, reduce the duration of stimulation, limit monitoring for patient convenience, lower the side effects and risks, but maximize embryo quality and maximize live pregnancy rates. In studies of the granulosal cell, not only were there increased FSH receptors, but there were also increased LH receptors. And that led to development of late follicular phase HCG or LH. Dr. Filacori in 1999 showed that LH promoted follicular genesis in synergy with FSH. It shortened the stimulation time, decreased FSH requirements, and overall decreased cost. And he was the first to show that LH enhances the efficacy and improves ovulation induction outcomes. Later, in 2005, he was able to show that you can completely replace FSH with LH, further and significantly decreasing the cost of the cycle. There were no differences in pregnancy rates. There were less small follicles at final maturation. And what they hoped that would show that there would be a decrease in ovarian hyperstimulation syndrome. But that could not be established. So what we started and set out to do, we started to do. We started to limit costs, the amount of medications needed, but more was needed. And the development of GnRH antagonists for the acute suppression of premature LH rise enabled the mild stimulation concept to be born. In fact, in the conventional stimulation, an LH surge was responsible for about a 20% cancellation rate. With the advent of GnRH antagonists, it went down to about 2%. This is just a slide showing the difference between two protocols. Conventional, on the top, utilizes a GnRH agonist, usually in the mid-luteal phase, for 2 weeks. FSH is then started at whatever dose is necessary, and then final maturation is triggered by HCG. In the co-treatment antagonist cycle, we utilize the natural endogenous FSH in the previous luteal phase, and then we begin stimulating with FSH around day 5. GnRH antagonists are then placed usually when either on cycle day 8 or when the lead follicle is 14 millimeters or greater. In this cycle, in this protocol, the final maturation is either triggered with HCG, but can also be triggered with GnRH agonists, utilizing their flare. And that is important in the reduction of OHSS. Holman, in 2003, in a prospective randomized study of 142 patients, separated 3 groups. Group A, conventional. Group B was the antagonist co-treatment, and the only difference between B and C was that FSH started on cycle day 2, or on cycle day 3. The GnRH antagonist was administered when the leading follicle was greater than 14 millimeters. And this is what he showed. He showed that, as usual, the number of oocytes per retrieved per started cycle was obviously increased in Group A, the conventional protocol. But what he further showed is that the percent embryo transfers per oocyte retrieval was markedly increased in Group C, where we started FSH stimulation on day 5 with the GnRH antagonist co-treatment. But overall, the percent pregnancy per embryo transferred and per started cycle showed no statistical significant difference. Heinen, in 2007, in a large randomized efficacy trial, looked at whether mild stimulation with the transfer of one embryo would compare with conventional long agonist treatment with the transfer of 2 embryos while looking at cost, multiple pregnancy rates, and reducing the patient's discomfort. And this is what they showed. Once again, the days of ovarian stimulation and the number of injections, obviously statistically significant. But the cumulative pregnancy rate and the proportion of pregnancies leading to a term live birth, absolutely or almost absolutely the same. They did show, however, that by transferring one embryo, the rate of multiple pregnancies was significantly lower. And this is a graph showing, a figure showing their results at the end of 12 months. This study took 12 months because that was the time they thought it would take for 3 conventional stimulation cycles to be completed. And at the end of this study at 12 months, you could see the single-term live birth rates were very similar. Verberg, in 2009, in a meta-analysis of 3 studies, 2 of which we've already seen, and 1 of which we'll see later, Dr. Bart in 2007, did a study and tried to investigate whether the low number of oocytes retrieved in mild IVF would be associated with impaired implantation rates. This is just their data, but it's better seen in this figure. The optimal implantation rates with minimal stimulation was seen when about 5 oocytes were retrieved. And it's also important to notice here that the highest implantation rate was seen with the mini as compared with the conventional. The optimal number of oocytes for implantation for conventional was between 10 and 12. In the mild stimulation, after 8 oocytes, it drastically decreased, whereas in conventional, it decreased, but more gradually. What were the conclusions of mild stimulation? It reduced the number of days of ovarian stimulation, decreased the number of injections, decreased the cost. There was less medication, less monitoring. There was less negative psychological impact. However, it preserved pregnancy rates and did decrease OHSS. But as usual, when something's good, maybe something can be better. And we revisited an old friend called clomiphene citrate. Because clomiphene had advantages. It was lower cost, it was orally administered, and it was widely available. In 1993, Korfman and his colleagues coined the term minimal stimulation. And it's gone by a lot of different names. Mini-IVF, light IVF, low-cost IVF. But it was a prospective, non-randomized study, and he compared 2 protocols. Mini stimulation, clomiphene, 100 milligrams, cycle day, 3 through 7, followed by a single dose of FSH on day 9. And he compared it to an HMG alone protocol. And remember, this was in 1993. And his purpose was simply to see if a different protocol would be attractive to patients as far as physically and economically. And what he showed again was that the number of oocytes obtained were markedly increased in conventional stimulation. But interestingly, the number of normal ferts per normal inseminated was statistically significantly higher in minimal stimulation than in conventional, 66 to 82%, while maintaining pregnancy rates, delivery rate per retrieval. Lou confirmed these findings using the same protocol as Kaufman, showing an enormous decrease in the number of ampules used with the clomiphene protocol, but overall the same cumulative pregnancy rates over 5 cycles and singleton pregnancy rate. Williams, in a retrospective study comparing the Mini-IVF protocol, and actually this is incorrect, it should be a standard GnRH agonist protocol. He compared both protocols in women less than 35 and greater than 35, and he also looked to see whether or not the addition of a GnRH antagonist in the Mini protocol made a difference. He showed that peak estradiol levels at the time of final maturation were statistically higher in conventional. He showed that the mature oocytes and the number of embryos transferred were lower in the Mini-IVF. And yet, the clinical pregnancy rate per transfer was the same. What he did show, though, was the percentage of patients able to cryopreserve was statistically significant in the conventional cycle. Terremoto in 2007, in the largest non-randomized retrospective study of over 43,000 patients, looked at a protocol of using continuous Clomid with alternating days of FSH starting on day 8. His conclusion showed that there was a reduction in the dosage of FSH, which reduced the financial and physical burden on patients. They also showed that the continuous use of Clomid in this Mini-IVF cycle would inhibit a premature LH surge while maintaining pituitary function. Also interesting, he also showed that pre-treatment with oral contraceptives increased the number of oocytes retrieved and their fertilization. In this study, again, equivalent pregnancy rates, but with this Mini-IVF protocol, it virtually eliminated OHSS. Ferretti, in 2015, using a light protocol, which interestingly was almost forced upon them by a law in Italy, decreasing the number of oocytes gained. And then after that law was repealed, the results seemed so good that they continued their light protocol. It utilized very similar 100 milligrams of Clomid, day 3 to 7, and used alternating doses of FSH on days 5, 7, and 9, and if needed, on day 11. These were good prognosis patients, and up to 6 embryos were inseminated, and 2 embryos were transferred. What this showed is, over 3 egg retrieval cycles, the greatest implantation rate and cumulative pregnancy rate was seen basically by the 2nd cycle. There was an increase in the 3rd retrieval, but it wasn't statistically significant. This figure really represents their data. The lower line represents fresh cycle pregnancy rates, which were about 64%. And the upper line represents the cumulative rate of fresh cycles and frozen cycles, with a pregnancy rate of approximately 70%. Now, this is important. A recent study a couple years ago in the New England Journal by Luke, just showing cumulative pregnancy rates with stimulation, showed that with 6 conventional stimulation cycles, the cumulative delivery rate was about 80%. And that 80% utilizing 80% success rate utilizing about 15 embryos. So these results were pretty robust. At our center, very similar results. Comparing good prognosis patients, our conventional versus mini-stimulation protocols show about the same live birth rate. And when comparing the age of the patient with the antral follicle counts, the live birth rate, again, similar per age groups, but showing a decrease in the 40 and above population. So, minimal stimulation conclusion, it decreased the need for FSH, it was low cost, it increased patient satisfaction, it was easily administered, with similar ongoing pregnancy rates with almost the elimination of OHSS. And just briefly to tie in with Dr. Silver's portion of the lecture, embryo quality. Mune, in 1997, evaluated donated embryos for genetic aberrations and mosaicism. And what he found was that chromosomal abnormalities, particularly mosaicism, was increased with higher stimulation conditions. He thought that controlled ovarian hyperstimulation might disrupt the mechanism involved in maintaining accurate chromosomal segregation. And by the studies this morning, I think there's a lot more than that. In Bart's paper, which was an excellent paper, tested to see if controlled ovarian stimulation for IVF affected oocyte quality. It was a prospective, randomized control trial comparing mild stimulation co-agonist treatment with conventional high dose. And he analyzed 10 chromosomes using FISH technology. His results showed that, again, the number of oocytes were higher in the conventional as well as the number of embryos. But he also showed a statistically significant increase in the percent abnormal embryos related to the number of embryos diagnosed. More oocytes, more embryos in conventional, but more abnormal embryos. And what did that ultimately end up in? That the average chromosomally normal embryo obtained per patient was 1.8 in both stimulation groups. And when biopsying additional cells, he showed that the percent mosaic embryos were markedly increased. And this study recently, in 2014, by Asser, had the same results. And this is just a summary of Bart's findings. But he suggested that in minimal stimulation, follicular recruitment and the initial stages of selection really remain unaffected. Whereas in conventional stimulation, because of the GnRH agonist downregulation, recruitment and selection was totally overruled, which may in fact disturb the complex interplay between folliculogenesis and oocyte maturation. Finally, half comparing women less than 35 years of age, 35 to 40 years of age, and 40 years of age to see whether there was an increase in chromosomal errors in oocytes. He also compared whether these chromosomal errors were increased with the number of oocytes retrieved. In the first ICSI cycle, there was a 10% increase between the patients less than 35 years of age and those between 35 and 40, and a 5% increase between 35 years of age and greater than 40 years. Those were statistically significant. He later looked at whether there was a difference between the first cycle and the second through fourth cycle, and again, showed a significant difference between the first and second cycle in the 35 and 40-year-old group, but not in the 40-year-old group, which most likely is caused by advanced maternal age. Then he looked at the chromosomal error rate. In the first group, it was a low yield group, 1 to 5 oocytes retrieved. In the middle group, it was the intermediate group, 6 to 10. And in the final group, it was greater than 10 oocytes. He showed in the patients less than 35 a marked increase in the number of chromosomal errors between the low yield all the way up to the high yield group. That difference really was not seen between the low yield and the intermediate group, but was seen between the low yield and the high yield group. And finally, again, no real difference in 40 or greater. So I started this talk saying, what would be the most ideal controlled ovarian stimulation protocol? And I asked, is more better, or is less more, or is even less less? Well, I think less is less cost, less medications, less stimulation, less patient inconvenience, less side effects, OHSS and pregnancy rates, and as a clinician who takes care of both multiple pregnancies and hyperstimulation, I can honestly tell you I am thrilled to death that there are less. Less abnormal embryos or better embryo quality with comparable live pregnancy rates. And I think Dr. Van Berkom and later this afternoon and Dr. Zhang will be going over natural IVF. Are we finished? Or is that pendulum starting to swing back? So mild and mini IVF is where more is less and less is more.